Thank you again, Natalia and Nestle, for inviting me here. And it's exciting and challenging to be the last talk after lunch, so I'll try to keep everyone engaged, and not to worry, we'll be stretching. So as Natalia said earlier, I'm a practicing physician. I see patients most of my time. I also do a lot of teaching of medical students, trainees, residents, and graduate medical education, and also continuing medical education. What I'm going to try to cover this afternoon is some of the challenges faced in clinical practice when talking about nutrition and weight management, and whether that's from a physician or an allied health professional in whatever specialty. I'm going to share some tools that are available that we can talk to our patients, and this is a great forum to have others share tools as well. I'm going to talk about group visits, which were mentioned briefly earlier this morning. And finally, I'm going to come back to the very important topic that Michelle mentioned about the importance of self-health and how that impacts patient care. Those three hats are meant to represent the three perspectives. So all of us here in the room are healthcare professionals of one sort. Some of us have direct patient care, others have impact on their patients based on patients, on what they study and what they do. And finally, we are all people, individuals. I think Natalia said this on the first day, we're all humans and we all eat. And everything that I talk about and that we really talk about healthy eating really applies to us as well. There's not really anything else in medicine and health that applies to everyone. Now, a couple millennia ago, Hippocrates said the function of protecting and developing health must rank even above that of restoring it when it is impaired. This is a theme that we've heard with prevention. Unfortunately, much of healthcare and medicine is urgent, and urgent is more sexy. The heart attack, the stroke, the surgery is more exciting in some ways than 10 years, 20 years earlier, what steps may have been taken to prevent getting to that point. This is some data from the United States from a few years back, and you can think about, at least in the US in 2000s, and you can think about other countries as well, what percentage of the population had all four of these healthy habits: not smoking, healthy weight, more than 5 fruits and vegetables a day, and physical activity more than 30 minutes, 5 per week. Pretty much. So it was in this series about 3%, which means, and we all know this, that we have a lot of work to do. Now, nutrition counseling, we haven't gone over too much data, and I'm not going to go into too much data apart from the fact that it has been studied, and it does work when done in settings with resources and time. This is just a quick snapshot of the diabetes prevention program, which shows that diet and exercise is more effective than metformin in preventing incidence of diabetes. It is recommended. I'm not familiar with all the global recommendations, but at least in the United States, several guidelines have recommended that physicians counsel their patients about nutrition. And this is not a surprise. We've heard this already, that it's not happening in the office. This harks back to people aren't learning it in medical school, and maybe that's why it's not happening. And if anything, as the rates of obesity have gone up in the decade from the 90s to the mid-2000s, the rates of weight counseling have gone down. Now, I'm listing here on this slide, you can read them yourself, in terms of barriers to effective counseling in a medical setting. These also have been mentioned over the course of the last 3 days, and as I was telling Roy, if you look at these barriers, many of these are similar to the barriers that children in schools and teachers and school administrators might face in terms of time, financial incentives, which is linked there, organized approach, does it even work, skills, tools. And I just want to remind all of us, sometimes as a practicing physician, I get a little feeling that it's futile, but there was some great studies that shows even in people, in this case, who were middle-aged, 45 to 64, if they improved their diet over a course of I think in the first top subject was 6 years, they had improved outcomes, and a subsequent study also showed benefit in outcomes with changes in diet even later in life. Obviously, we want to work with the prenatal, natal, early 1,000 days, but in my practice, the horse is out of the barn. So this is just one example. I know we're talking about population health and studying RCTs, but really when it comes to the practice of a doctor and a patient in a room, it's really one-on-one. And this is just one example of a 45-year-old woman who, she didn't smoke, but otherwise did not have any of the other healthy habits. And in this particular study I showed earlier, the BMI was a little bit more liberal. So what can we do using this lady as an example to help her? So let's look now, putting on a different hat, taking off our physician practitioner hat and putting on the patient hat. What are some barriers that patients might face in taking care of their own nutrition? And my point here is that many of the barriers are the same. So in terms of the patient perspective, they also don't have time. Finances is often more of a consideration. They don't have an approach. There may be family factors. They don't want to offend their family, and they also don't have the tools and the skills and the training. So it is really a effort at all levels. And just to get this point across, when we look at our own selves, so just as health professionals, physicians, dietitians, what barriers we may face. I think an added barrier here I'm going to add is when traveling, it's extra hard to practice healthier habits in terms of finding the time to get some exercise in, for example, and we definitely have a great option of healthy meals, maybe too many healthy meals, but some of the barriers are very similar. So I'm going to spend the next few minutes talking about some tools and using the perspective of the clinician and then the patient and then as ourselves. So for starters, some basics. And this is what I think when we're talking about how we train physicians in medical school or residents or even practicing physicians, there needs to be a common denominator. And what is depicted here is some form of dietary assessment, and I'll get to that in a moment. Checking a weight at every visit, which is a very simple tool and it can be tracked. And then providing some sort of either mention or importance or counseling if you have the time. This has also been mentioned that as a physician, we have a very powerful voice and patients respond to that even if we don't provide the actual counseling. I think the gentleman earlier this morning said how whether you're a cardiothoracic surgeon or endocrinologist, you may not have time to go into the counseling in depth, but recognizing its importance really gives credence for the patient. Now, just briefly in terms of dietary assessment, also there's numerous tools available. I'm just going to bring your attention to the last one on the list. As a busy physician, I generally don't have time to do a detailed assessment. I often ask, how many fruits and vegetables do you eat per day? And that gives me a springboard of whether to focus on some other aspect of their health, or if they say, does apple pie count? Then I know that I need to spend a little bit more time with that person on that topic. This is also simple, and I'd be interested to hear if everyone does this in clinical practice, but checking the weight at every visit. If you have a height, you can calculate the body mass index, and if you have electronic medical record capabilities, that is done automatically. And this can be tracked from year to year, and whether it's 1 or 2 pounds or 1 kilo per year may not seem like very much, but after 10 or 20 years, that could be 10 or 20 pounds or kilos, and that can push someone from normal weight to overweight to possibly even the over 30 obese category. Waist circumference is also another good measure. It's not as simply done in the office, but that's another good measure to consider. And now I'm just going to share with you some simple tools. Now, this is very cultural. In the US, we have what's called a problem list where we itemize all the problems that patients have. So it might be, for example, hypertension, hypercholesterolemia, diabetes, and what has been shown with this study and others is if you put the name obesity on the problem list, the clinician is more likely to discuss it with the patient and to have a discussion. So this harks back to even trainees, medical students. Even if someone hasn't had a lot of training, if they see that, it's more of a prompt to have that discussion. This came up yesterday, I think, in Roy's talk, that as with children, they may not realize that they are overweight, or their parents may not realize. Adults, too, may not realize that their weight is in the either overweight or obesity category, because sometimes many of their friends or families or neighbors also are in that category. So the reason this is important is because people aren't going to make steps to change if they don't realize that there's a risk. This concept of language also is very important. As you are well aware, obesity and weight is a very sensitive topic to talk about. And in this particular study, they looked at which terms patients preferred when talking about weight. The top is the most preferable, and the bottom is, as you go down, least preferable. And what I wrote at the bottom is the concept of people-first language, that people are people before they're diabetics or before they're obese. So it's better to say a person with diabetes than label them a diabetic. So this is subtle, especially for those whose first language is not English, but can be very important when talking with patients. And I've included here some quotes of how you can phrase terms so that they're less sensitive. So for example, Mr. Jones, how are you feeling about your weight at this time? I'm concerned that your weight is causing or will cause problems for you. You're on a path towards heart disease. These are all very, very non-judgmental and general topics that people can realize that the physician is concerned and not being judgmental. This is another simple tool. Many of us in the audience write prescriptions, and those who are clinicians of adult patients write for blood pressure medications and cholesterol medications. Why not give them a prescription for nutrition or exercise? So it seems a little silly, but I've been doing this with my patients, and sometimes I say put it on your refrigerator or put it in your cupboard, so that way it's a reminder of what to choose or what not to choose. And then if you have the time, even if it's only a few seconds, trying to commit the patient to set a goal. And this gets into motivational interviewing and coaching with patients. Again, many clinicians don't have the training and don't have the interest and don't have the time, and possibly this could be referred out to somebody else. But if you're having that discussion with the patient, getting them to commit to some change, that way next time you see them, you can follow up on it. So there's no way one person can do it all. There's critical importance of the team, as we've heard, what you have in your office, other health professionals, nurses, nurse practitioners, physician assistants, dietitians, chefs, psychologists, exercise physiologists, and weight management programs. There's a lot in the United States of remote management, electronic visits, so that's another great way to reach patients remotely between visits. And what I write at the end is remote management. There's such a growing field now with apps and digital capabilities, both for tracking and counseling. This is just one study from 3 years ago now that was called TEXTME, and some of you may have seen it. It was a randomized trial of more than 700 men and women for secondary prevention, and they got 4 texts a week for 6 months. And they were semi-personalized. They were on the order of keep a calendar of how you walk, how often you walk, have you, to add interest to your meals, try a new fruit or vegetable. So they got these at random times during waking hours during the week as a prompt to remind themselves to eat better or to exercise more. And they did show some benefits in intermediary outcomes, such as LDL, blood pressure, body mass index. Now, again, this is 3 years ago, and this is somewhat rudimentary because technology has developed a lot. And now, as we heard a little bit about yesterday, there's so much potential with smartphones and GPS tracking and monitored self. and potential for tailored intervention that I think one of the challenges is how to study it, because by the time you design a study to study it, the technology is outdated and people have moved on to something else. So one of the challenging things as a person who is in the translational implementation sciences, it's great to have all this science, and by the time I try to put it into practice, sometimes it's a moving target. So now I'm just going to spend a few minutes, just some simple tools to helping patients change their behavior and eat better in this case. And I just put up again, the prime barrier for probably everybody is time. And I have this nice quote on my wall. If anyone knows the source, let me know. But it says, if you don't have time to be sick, you must take time to stay well, which is self-evident. And I've included it. It's on that top middle portion of my exam room. So because I too sometimes am lacking time, my patients have to wait for me. So while they're waiting, at least they're looking at some fruits and vegetables and some quotes and some pyramids there. And depending on the nature of the office visit, sometimes I do problem visits for chronic disease, sometimes acute visits, sometimes comprehensive visits. I learned yesterday that in Switzerland there's no preventive care that's covered, so that's kind of interesting. It's a whole other topic. So depending on the nature of the visit, there may be more or less time to talk about nutrition. And if I do have 30 seconds or 60 seconds or 90 seconds, I might go for some low-hanging fruit. So for example, if someone is drinking sugar-sweetened beverages, try to help them cut back on that and replace it with a less caloric beverage. If the discussion goes towards carbohydrates, steering them towards whole grains rather than refined grains. Again, steering them towards the liquid oils versus the solid fats. And we saw this earlier this week, if there's time to actually look at some nutrition labels, and these can easily be brought up online. We have computer capabilities in our rooms where I can pull up information. And then here's just a simple topic. We've talked about this a little bit, but if someone wants to estimate how many calories are on this plate briefly, anyone? Yeah, so let's say 450. So yeah, it's got a lot of greens and not a lot of high caloric density. How about this one? It's got bread, it's got a little bit more yellow. So the point is it's about double, and the reason being is that in part the plate is bigger, so you can fit more on the plate. And those are sort of some of the tools that I try to share with patients as well. And this also gets to the point that we heard a lot about yesterday and the day before. All the talks are blending in, so I heard this multiple times from various people. The whole concept about psychology and behavior economics as it is applied to food, and that knowledge is not equal to behavior. There's a lot of steps that are in between. And I'm not going to go into all these concepts of anchoring and marketing and cues and companions, which we heard a little bit about in the various talks, but they can be very powerful, and I'll share with you how I talk with my patients about them. Just one example, companions, depending on who you're eating with, your choice of food might change. So when I'm eating with someone who eats less meat than I do, I might eat less meat, for example. These are just some tips for mindlessly eating better. I think we heard this message as well. One of the fun parts about being the last speaker is to be able to tie in everything that we heard and to reinforce it, that you want to make the healthy choice the easy choice, and you want to mindlessly eat better. So you don't want to be tempted. You want to have your environment very well controlled. If you hide your cookie jar, if it's not in front of you, you're less likely to eat it. This is another simple book that I share with my patients sometimes. There's 60 rules in there that are very simple, such as eat food, which, like Michelle said, and she uses in her cooking class. And we've been eating a lot of good food recently. Where I come from, if you go to the supermarket, many of the products that are sold there, I sometimes don't recognize what it is by reading the ingredient label, so it's not always simple. And it's not food if it came through the window of your car. And if it came from a plant, eat it. If it was made in a plant, don't. And then just a few words about cooking, which we heard a lot about this morning. There's been observational studies that show that in communities and countries that cook less, the rates of obesity are higher. This quote on the car says, on the van says, "Keep your kitchen clean, dine out," and they're working against my message. This is a photo near my hospital. That's my hospital in the background. Thankfully, there is a movement to cook more. So this is Dining In, an article about cooking at home and how it's more healthful. And then what I'm going to transition to now is talking a little bit about group visits. Just a show of hands, how many people in the audience here have either seen one or done one or have heard of them? So some folks here. And if you look at this concept slide here, on the bottom left, one provider to one client at one time, that's traditionally how medicine has been practiced, one-on-one, one physician, one patient, giving advice, dispensing recommendations. If you move to the right, one provider to many clients at once, that might be a different model to deliver some of these messages. I'm going to focus on something called a shared medical appointment, which is a type of group visit, which I'll explain in a moment. But basically, the word medical means we talk about medicine and problems, and part of the reason there is to call it a medical appointment. It's not a nutrition teaching session. And as I'll share with you in my experience, what I do in the appointment is what I would do behind closed doors, except in front of a group. I wouldn't do everything I do behind closed doors, but it's a group setting. And the top left there is me with my patient. No, usually there's no desk between us. And I found that oftentimes I was saying the same things to patients over and over again in terms of healthy eating, what to eat, what not to eat, how to watch their psychology. And because I was limited on time and I am obviously interested in food, I decided to try this group visit. And Dr. Hauser and I actually did this together about 10 years ago after listening to a talk that encouraged us to try it. And basically, there's some logistics involved, but if you look at my usual schedule, this is what a typical, at least in my hospital, physician's schedule looks like in terms of every 15 to 30 minutes seeing a different patient with either diabetes or arthritis or cancer history, and then whatever might come in that morning, urgent slots. So instead of that, think of a environment. This is not me, and these are not my patients. This was in the New York Times. But this is a similar example of one physician, I think in this case, this is a physician with 8 to 10 to 12 patients, and talking about their health conditions in a group setting, and then offering advice to them in a group setting. So this is the picture of my exam room that I have available. Actually, it's my conference room. And as you'll see, it can comfortably sit 12 to 14 people. I have a whiteboard. I have capabilities to project from the internet. I recruit my own patients who have metabolic conditions, so anyone who has high blood pressure, cholesterol, weight, and really 90% of my patients would be fit for this appointment. I have my usual staffing, and they get weighed, they get their vital signs checked, and they have a short pre-visit questionnaire, so that forms the basis of my medical appointment. And then after a short overview, we start talking about medicine, and I'll get to that shortly. And not to forget, I'm always encouraging not only you guys to move, but my patients to move, so we do have a mid-session stretch halfway through the 90-minute session. And then the unique part of what I do with these sessions is I actually do a cooking demonstration. And if you notice this picture here, there's no kitchen. So part of my goal to get across here is that teaching kitchens can be very expensive, even portable ones, and there's a lot that can be taught in a setting without a heat source and running water with some creativity. If you look at this graph, you can take a moment. it says medical complications of obesity, and you can put in there poor nutrition, really affects every part of the body. And if you tell me some condition, I can find some way that nutrition is related. So it really can come up, whether you're talking metabolic conditions, psychiatric conditions, malignant conditions. So there's never a shortage of topics that we can talk about with the patients, and each patient comes with their unique medical conditions, and I address both what the patients bring up, and then if the patients aren't very talkative, I talk about some general topic that they don't have to feel uncomfortable talking about their own condition. Weight loss strategies is often a common concern that people want to hear about. And I use my whiteboard as I use it with my students, so it's a really interactive, and the patients are actually teaching each other as well. And here's where the fun begins, or it's ongoing, but while I'm talking about nutrition, while I'm talking about their medical condition, I throw in the nutrition. So when we talk about fatty liver, we can talk about their carbohydrates. When we talk about trying to lose weight, what are some strategies for weight loss? And here also is where I can bring in all the psychology. Now I have the time to talk about plate size or reading food labels or why sugar-sweetened beverages should be minimized. And I think I mentioned the session runs 90 minutes. And not only is that a long time for a physician to be spending with the patients, but also, if you think about it, the patients never spend that much time with their physician unless they're in the hospital and having family meetings, and it's the other end of the spectrum. So it's really a unique opportunity for both ends. This article was last year, and it was to remind me that prescription and recipe in some languages, including Greek, which is where I'm from, is the same word. So if you think about it that way, you write the prescription, it's actually a recipe. So speaking of some recipes, I'm just going to show a few pictures here of something that can be done simply in an exam room. What we do is we have a sink next door in our small kitchen. Whoever wants to participate washes their hands. And then I bring in cutting boards, knives, mixing bowls, and the ingredients. And we prepare some food. So this, an example, is Greek salad. It's very simple to prepare. You bring in some nice crusty bread, and then at the end you eat it together and talk about how this is a good thing to put together. And what's actually fun is after patients do this, they go home and they do it with their families and they incorporate it into their repertoire. It's really a see one, do one, teach one, eat one example. This is actually, Michelle, Dr. Hauser. We were preparing a grain dish here, and it definitely helps to have colleagues who are chefs, because when my chef colleagues come, they're the ones that are preparing the meal and can talk and chop at the same time. I tell my patients I can't chop and talk at the same time. This is another day, another example. This was smoothies, so I brought in a blender, a whole bunch of fruits and vegetables and liquid, and we put together some nice smoothies. And there is an article here that we published based on our experience, a feasibility trial. And another one of the recipes that are on this list is what you mentioned yesterday, is just bringing in some yogurt, fruit, and nuts, mixing it with patients and eating it together. Many health professionals, especially those of us that are interested in nutrition, know what a healthy meal looks like and how to put it together, but oftentimes patients don't. I won't go into billing because that's very location specific, so if that's something you're interested, you can ask me. And another important concept to think about, many people might ask about confidentiality. In the United States, we're very interested in confidentiality. So when people come to these sessions, I ask them to sign this, just saying that they're there voluntarily and that we don't have to talk about anything they don't want to talk about and they can leave, and that they agree not to talk about specific details outside of the setting. Now, that being said, patients, when they're in a group like this, divulge a lot of personal information and they love to talk, and it's really a great environment for peer-to-peer learning. They allowed me permission, confidentially, to take this picture. So this is an example of me in the background pulling up something on the internet, and we were cooking and using stretch bands and just having fun. And I come back to the lady that I mentioned earlier. After a few years, she actually came to some of the sessions and really took it to heart and changed some of her habits at home. She actually changed several of her behaviors. And again, an N of 1, but this person was helped. And just to give you some comments from some of the other patients, again, more of a qualitative, but one of the things that we forget about is that when we see patients in the office, we see them for maybe a half an hour, maybe more, once or twice a year. The rest of the time, they're on their own, so they're making decisions on their own. And that's one time for 90 minutes they can really focus on their own health. And one quote is, "It inspired me to try harder, reminding me to take care of myself." And then others' questions reminded me of questions I may have forgotten. So as a physician, I don't have all the conditions that the patients have, of course, but patients have each other's conditions sometimes, and they can learn from each other. So now the patient likes it. What about the physician? So in a traditional setting, I'm seeing patients for about 3.5, 4 hours, and I have to chart, and at the end of the time, I'm exhausted. SMA stands for Shared Medical Appointment, the group visit. Time-wise and in terms of income-wise, it's about the same, but I really feel energized. And this is really important, especially as Dr. Hauser mentioned in this era of there's a lot of physician burnout. So I encourage people to consider something like this, and I'd be interested to hear, again, in different settings, different things might work. So now I'm just going to, for the last few minutes, talk about self-health. Again, putting on our third hat, and these hats are constantly changing. Dr. Hauser already mentioned the work of Erica Frank, who nicely showed that how we care for ourselves reflects on how we care for our patients for eating and other health examples. In this one study by Dr. Bleich and colleagues, she looked at a cross-sectional study of 500 primary care physicians and compared those with normal body mass index as compared to those physicians who were overweight or obese, and those with normal body mass index were more likely to engage obese patients in weight loss discussions and had greater confidence and ability to provide diet and exercise counseling. And I think one of the points of this study is that if we help physicians improve their health habits, it can really impact a lot of patients. There's a culture during training that we don't take care of ourselves, and like we've come back to time and time again, prevention is really key. And bullet number 3, physicians are notoriously bad patients. I'm not sure if that is everywhere, but definitely in the United States. And we really need to take a step back and make sure that we take care of ourselves and have our own wellness as a way to take care of our patients. The Institute of Medicine, a body in the United States, did come out with some recommendations that healthcare professionals should act as role models for their patients. Now, not all food served at medical meetings adheres to guidelines. This was a meeting I recently went to that had sugar-sweetened beverages. This is for doctors and a lot of those were the only options. There weren't any other options. Here we have a lot of options, which is good. You can pick the healthier ones. This is an example of a nutrition conference, which I think some people in the audience were at, which has, I would say, healthier options both for breakfast and for lunch. And then Dr. Hauser mentioned this conference, which, if people are interested, is a great place to both learn about hands-on cooking skills and to meet like-minded individuals. And finally, I really took things to heart after talking and thinking about all this. This is a picture of my office, and that's me with my sit-stand desk. As you can see, I can't sit very long. And on the refrigerator, on my microwave, is my fruit to remind me to eat that first. I'm going to end with another quote by an ancient Greek, Hippocrates, "Let food be thy medicine, medicine be thy food." Thank you very much.